The challenge in relapsed refractory mantle cell lymphoma is the proliferative p53 mutant cases. These patients, because of these p53 mutations, tend to be more chemotherapy refractory. These patients also tend to be more refractory to BTK therapy based on what we've seen. And it's not clear that agents like venetoclax will rescue this phenotype. It seems like these patients tend to fare pretty poorly, regardless of our novel agents and our chemotherapeutic approaches. And so I think really to rephrase your question, I don't think the answer is what do we do with relapsed refractory mantle cell? My opinion is, what do we do to prevent relapsed and refractory mantle cell? How do we think about combining our novel agents to hopefully one day prevent this proliferative relapse, but at a minimum, increase the length of time before that emerges? How do we think about CAR T-cell therapy as one of those novel approaches that we can integrate into our frontline therapeutic regimens, whether that be a BTK-based, whether that be lenalidomide-based? How do we think about bringing in, again, all of our novel approaches to bear in mantle cell lymphoma? And I hope, in following what has already happened in CLL and following what has already happened in myeloma, we begin moving further and further away from chemotherapy in a disease that is defined by impaired DNA damage response.
Well, in the absence of being able to cure mantle cell, which obviously I hope we can do someday, just like other, I'll call it mantle cell and indolent lymphoma. Sometimes it is, sometimes it isn't. But other lymphomas where we don't have a curative intent. Obviously, we need the longest responses from each agent so that we can extend patients' quality of life, progression-free survival, and overall survival.
Ongoing challenges in treatment of relapsed refractory mantle cell lymphoma. If you asked me that question 10 years ago, I would say it's a big challenge. So right now, it is less of a challenge because we have several target therapies, immunotherapies, CAR T cells. I think that the challenge is to perform a risk stratification and do not overtreat those patients that you are going to affect their quality of life, and you might, so that's, I think, the challenge for me at this time. So what should I offer to my patients this day that we have so many target agents, so many clinical trials, so many combinations? And the answer is, if it's a patient with asymptomatic relapse, I might do watchful waiting. Or maybe a clinical trial with 3 drugs that have a good safety profile. If a symptomatic relapse, so it depends. If a patient with bulky disease or a patient that now has a blastoid variant or has pleomorphic, very aggressive mantle cell lymphoma, definitely is a patient that, if he can tolerate current immunotherapies, I will be thinking about those. Sometimes having more options could represent a challenge, right? Because when 10 years ago we don't have options, so I see it that way.